Then finally, we couldn't leave lymphoma without talking about CAR T cells. We have 3 different studies, one by Nilapu, one by Abramson, one by Schuster, 3 different companies, 3 different drugs, approvals that are either have happened or that are potentially in the works. And at every meeting, we see more and more about CAR T cells and lymphoma. Your thoughts on kind of what's new at ASH? Obviously, some of these abstracts we're going to see at the meeting because it's not yet public, but what are you going to be looking for?
I think it's the reason why we see all these updates, because there's a tremendous amount of interest in this data. So people jump into like an updating with the short-term follow-ups, but that, again, that reflects the interest in the field. So you're right, these 3 abstracts being presented before, there's mainly updates. I think the one that I'm looking for is the Zuma one, which has now the longest follow-up. It's about 1 year. Everybody wants to see how many will remain in CR at 1 year, because this is a good benchmark for patients with diffuse large B-cell lymphomas. The other one is, I think, interesting, but they still have short-term follow-up.
Great. And then to move and to finish the lymphoma section of our program with the PRIMA study, Gilles Salle and colleagues presented. Now we have as long as 10 years of follow-up with the PRIMA study, which basically looked at rituximab maintenance after chemo-rituximab as initial treatment for follicular lymphoma, and longer-term follow-up now suggesting, again, no difference in overall survival, progression-free survival data being presented, toxicity long-term data being presented. How do you think, given that a lot of people in practice, one way or another, either think about using rituximab maintenance, and whether or not they actually do, a fair number of patients do receive it, what is your thought as this study helps
you have
them?
to put this in context. So this is the PRIMA trial compared our chemo versus chemo without maintenance rituximab. Clearly the data is very nice, 10-year follow-up, median progression-free survival is about 10 years. It's remarkable. But you have to put this in context, because there's a parallel trial from Italy, which is a full, I think, 5, which did not use maintenance, with R-CHOP with no maintenance, also reported 10-year follow-up, and then published in JCO about a month ago with about 10-year progression-free survival. So it's confusing, I think, for the average person. My default, I would be interested to hear your opinion. For now, I reserve the maintenance for selected patients. My default is not to use maintenance for the majority of patients.
Agreed. I would say I talk about it with my patients, but in the absence of an overall survival benefit, the patient has a lot of flexibility. Some people really want to push being able to stay in remission. Others say, you know, I'd rather take a break from coming in for therapy. And the good news for patients is that they have a choice, which is certainly nice. So, and then finally, in the last 15 seconds or so, you're presenting some data using an immune checkpoint inhibitor, atezolizumab, with bendamustine and obinutuzumab, one of the first studies with immune checkpoint inhibitors and chemoimmunotherapy. Where do you think that's going? I know it's early, but...
Yeah, it is. I think that's what the field is heading right now, to incorporate these new agents that may not have overlapping toxicities with frontline regimens. So atezolizumab is a PD-L1 antibody. The advantage of atezolizumab is I'm not interested mainly in the concurrent administration with chemo. I'm mainly interested in the adjuvant or maintenance setting, because I think these agents may have a better chance of eradicating minimal residual disease compared to passive immune therapy like an anti-CD20 antibody. Great. So the MRD data, I think one should focus on, not just the overall response.
Great. Well, thank you, and we'll come back to some of these topics in the question and answer session in a few minutes, but now it's time to move on to AML.